Hello, welcome to Anatomy Physiology, Chapter 8, where we're going to talk about the skeletal system. Now, there's a lot of material in this chapter, but since most of it is anatomy and not so much physiology, I'm going to refer you to two other videos that I have on my YouTube channel. One of them is over the axial skeleton, and the other is over the appendicular skeleton. So to name the bones and to look at the processes, the things that stick out off of the bones, the points of attachments for muscles and ligaments, you really need to look at the lab videos. So I'm going to cover some things that we didn't cover in lab in this particular lecture. I like this picture. It's not technically accurate because there are differences in skeletons from different ethnicities. So if you watch shows like Bones, and they're always saying, well, this is from a Native American, or this is from somebody from Africa. So they tell you that there's a little bit of difference in the bones. But basically, the reason I like this is because I like the movie Forrest Gump. And if you haven't watched Forrest Gump, you really ought to, and you'll understand why this is funny. In the first chapter, you had an appendix that told you the various words like sagittal and coronal, distal, medial, lateral, superior, inferior. So the other thing that we learned were some of the regions of the body. We learned the frontal region and the occipital region. And why this is nice, as we go through when we're doing the skull, you're going to find that the frontal region is where the frontal bone is, and the occipital region is where the occipital bone is. So then, later on, when we learn the parts of the brain, you're going to find that the front of the brain is the frontal lobe. So these words carry over chapter to chapter. So many organs are named for their relationship to nearby bones. And to understand how the muscles move depends on the knowledge of skeletal anatomy. When you're looking at things that stick out on the bones, they are landmarks. So you can say, okay, so it is superior to the condyle, or it is lateral to that particular fossa. So you have some landmarks like that you need to know. And again, we talk about those in lab, and that's where you have the bones and you can handle them. I can't sit here and talk to you and put mental pictures in your head. You really need to hold the bones in your hands and look at them, and look at the back, look at the front, look at the top, look down on it, see if you can find the points of articulation where the other bones meet, or where the ligaments or tendons attach. Now, I will tell you this too. This is a general anatomy class. It's for anybody who wants to go into any of the medical fields. If you're going to go into radiography, for example, you're going to need to know every single bone, and you're going to need to know the landmarks on the bones. So you're going to go much, much more in depth than someone who's just going to go into nursing, CNA, something like that. So if you know what you're going to do when you get through this program, what degree you want to come out with, you can spend more time or less time studying the bones. Here's just a representative picture that I threw in here to kind of give you an idea of what's going on. So in the general class, we learn about the head of the femur and the neck and the greater and the lesser trochanter. But look at all of the other things that someone who is studying radiography needs to know. The acetabulum, we need to know. I expect you guys to know that. The sacroiliac joint right there, the iliac crest, the ilium, the ischium, the pubis. These are things that we learned in lab. We learned about L1 through 5, we learned about the sacral fused vertebra and the coccyx. But look at all the other things that you're expected to know if you're taking a radiology class. The number of bones changes from person to person and from age, from before birth, right at birth, puberty, and on up through old age. So when you ask how many bones there are in the body, you have to then say, what age are you talking about? The two subdivisions, I mentioned those earlier. The axial skeleton would be your skull, your vertebra, your ribs, and your hyoid bone. All the rest of the bones are considered to be your appendicular skeleton or your appendages. So that would be your arms, your legs, and your shoulder bones. And the hip bones are also considered to be part of the appendicular skeleton. So here's your nice little picture telling you that. So at birth, you have about 270 bones, but oddly enough, the number decreases, but it also increases. So you're going to fuse the bones of the skull, but you're going to add a kneecap because you didn't have a kneecap. And then along about the time you're 9, somewhere between 9 and 12 years old, right before puberty, you're actually going to grow a wrist bone, a new carpal bone that you didn't have before. So you're constantly adding a bone or fusing bones. So 270, give or take a few at birth, 206 in you, because most of you guys are past puberty, but you're not nearly as old as I am. You're going to have extra sesamoid bones. They look like sesame seeds. That's why they call them that, except for they're bigger than that. And here is some real news, not fake news. But because people nowadays are staring down at their phone, they are actually stimulating the skull to grow extra tissue on the skull to help support the head in that abnormal position. So they're finding bone spurs, which they're calling horns, on the back of people's heads, especially youngsters, because they spend so many hours on their phone. And about a third have these new growths. So it's going to be interesting when they, in the future, dig up our bodies and find our bones, and they find these bone spurs sticking out. And they're like, wow, what evolutionary thing went on that caused the skulls to be different in these people? So here's actually a picture that they're finding on the back of people's skulls. Right there. And here's someone who had repetitive motion of their thumb, and they grew a new sesamoid bone right there. In the lab, you probably looked at articulated skeletons, and those are the ones that are put together. So they've wired them so you can see which bone goes where and how they articulate or how they make joints. And then you should have had disarticulated bones where you have the individual bones so that you can look at the surface features at the top, the bottom, the places where the bones come together, the articular surfaces. I show you this picture partially as a joke, but the unusual fad of wearing your pants down around your ankles. Here's where someone said, well, it must be because your torso looks like this. But because people are wearing their pants down there, they're actually having to splay their legs to hold the pants part way down. This is causing hip dysplasia. So they're actually seeing some abnormalities of the hips. So this is kind of in jest, but it is actually damaging kids' legs when they wear them like this before puberty, right at puberty, when their bones are really growing. Remember that anything that sticks out on a bone is called a process. If the process makes a hole, it may be a meatus. If it's a line, if it's a crest, if it's a hole, it's called a sinus. If it's a cavity hole, it's a sinus. But if it's a hole that something passes through, it could be a foramen or a canal. Something that sticks out sharply could be a spine. Like this is a spine. But this part of the scapula is also considered to be a spine. At the bottom of the femur, you have condyles, and right above the condyles, you have epicondyles. So we know epi means upon. We're going to use that a lot. So we talk about dermis, then we talk about epidermis, condyles, epicondyles. And if you have a lump that looks like a potato, it's either a tubercle or a tuberosity. So if you have a potato-looking lump stuck on. Your skull is made of 22 different bones. They're held together by sutures, which are fibrous joints or immovable joints. And then you have several cavities. So you've got your eye sockets. You have your nose. One of the jokes that I always tell is, how do you break a little kid's finger? You hit them in the nasal cavity. Stop and think about it. Little kids are always walking around digging for gold in their nose. And then, of course, your mouth is a cavity. Your ears are cavities. And your sinuses are cavities. You learn that the largest hole in the skull is the one that allows the spinal cord to come down and go into the vertebral column. If you have several holes, we call it foramina. So a foramen is one hole, foramina is a set of holes. And we didn't really talk about the sinuses, but we did talk about the frontal bone, the sphenoid, the ethmoid, and the maxillary bones. So let's look at that. These sinuses is like, why do we have them? They just fill up with mucus and have pressure and they hurt and we have sinus infections. Well, they add resonance to your voice and they also keep your skull from being solid bone. So I was always mystified, how can you have pain in a hole? I mean, there's nothing there, it's a hole. But it's the lining of that hole that gets infected and inflamed, and then fluid goes into the cavity and pushes on the tissue, causing pain. So here's the sphenoidal sinus back here. And then the frontal sinus right above your eyes, the ethmoidal sinus on either side, and the maxillary sinus. So it's pretty big, the maxillary sinus is. As we go along from chapter to chapter, in one chapter we learn bones, in another chapter we learn muscles, another chapter we're going to learn about joints. And it's nice to step back every now and then and realize that everything fits together. It's not just empty bone. You've got the bone, and then you've got the brain inside of the bone. And then you have those sinuses. You have the different muscles. You have different nerves, like the optic nerve. You have tissues. For example, you have this big fatty adipose pad around your eye. So it's important to know these various things. Your tongue articulates with the hyoid bone. I mean, how strange is that? Your hyoid bone's down on your neck. When we talk about the brain, we're going to learn about the connective tissue that surrounds the brain. So the brain is actually in a multi-layered sac. We're going to learn about that, the dura mater, the meninges. So sometimes you hear about somebody who has meningitis. So it's an inflammation of the sac, the membrane that surrounds the brain. I think it's fun that the thickest layer of the membrane is called the tough mother, the dura mater, the tough mother. This is an artificial designation right here, but I'm going to go ahead and mention it because if you look at the skulls in the laboratory, you notice that they cut the top off. Well, when you're in the autopsy room, a lot of times they'll cut the top of the skull off that way so that they can lift out the brain and look for things that are, might have killed the person. So this is not a real bone. It's just the way you cut the top of the head off. So they just gave it a name, the skull cap, the calaveria. And I found this kind of funny. So here's a doctor. He goes, "That's what I'm afraid of." And the other doctor says, "What?" He goes, "Skeletons." So we're getting close to Halloween right now, and why you would be afraid of a skeleton? They cannot move unless they're attached to muscles. For those of you who don't have me for lab and you only have me for lecture, I'm going to just talk about one bone in particular. So you have 8 cranial bones. You have 1 frontal, 2 parietal, 2 temporal, 1 occipital, 1 sphenoid, and 1 ethmoid. The occipital bone lies over the occipital lobe, and when you look at your eyes and you think about going straight back from your eyes to the back of your skull, that's your occipital bone. And it's a really easy place for a parent to hit a child. So you got some little kid running around begging for candy or crying or hitting their brother or their sister, and you just reach down and you hit them with the flat of your hand right on the back of their skull. So you're hitting in the occipital region. Well, your brain is suspended in fluid inside the skull. And so when you do that, you actually jam the front of the brain up against the frontal bone, and then it recoils and hits back against the occipital region. And if you bruise the occipital part of the brain enough, the child will go blind because that's the part of the brain that understands the light that's coming in your eyes. So the information goes through the optic nerves, and the occipital part of the brain is the part that processes that information so you can see. So a kid can have perfectly good eyes and be blind. So if you ever see anybody hitting a child in the occipital lobe, tell them to quit. When you're looking at the skull, you're looking down, you're learning all the little parts of it. You're learning the cristagalli and the cribriform plate, the sella turcica, where the pituitary hangs out, the foramen magnum, which is the big hole that allows the spinal cord to leave the brain. Try and imagine what it would look like if you had the brain in there also. So it's kind of easy, the frontal lobe, to see the frontal lobe of the brain. And then over the ear, there's the temporal lobe. And there's the external auditory meatus, which you and I call the ear canal, where you stick your finger to get earwax, right there. And then the cerebellum, the part of the brain for balance. So try to put these things together and don't just learn the skull by itself and just learn the brain by itself. This is a nice color-coded picture that shows you the various parts of the skull. And since it's colorized and you have a little key over here, it helps you figure out exactly where the different parts are. So you can always take this video and pause or take a screenshot because it helps, I think. The lab manuals are usually black and white, and so you can go on the internet and find some really cool stuff. Just be careful and don't go to Bubba's website. Make sure you go to like Harvard or Yale or, University of Kentucky, Eastern Kentucky University, KCTCS. Another thing that'll help you learn about the different bones is write them down. Write them down. So here's a kind of a fun thing. Somebody did this one, showing the ilium, the ischium, and the pubis, the femur, the patella, the tibia, and the fibula, the tarsals and the metatarsals, the phalanges. So this is kind of neat. And then they put all the ribs in place, scapula, clavicle. I thought this was rather clever. And then here's another one where they're showing you the maxilla and the mandible, and where your teeth are, and the zygomatic bone that gives you your cheekbones. So this is kind of fun. This is another really nice colorized picture so that you can see the sphenoid bone right there. You can see the lesser wing and the greater wing. Almost looks like a butterfly. So you can see that. The temporal bone is showing up as purple. The cribriform plate is in the ethmoid bone right there, which is surrounded by the frontal bone. You can take a screenshot of this. This is the inferior view. So if you tip it up, you take the jawbone off, and you look up, and you can see the hard palate. You can see the palatine bone. Of course, you always have a nice landmark like the foramen magnum, the large hole. One of the hardest bones to keep up with for me is the vomer bone, because depending on which view of the skull that you look at, it looks completely different. So here's a median section. So you cut it in the middle and you're looking inside. It's nice. You can see the sphenoidal sinus in there. So that's kind of nice. The cristagalli looks completely different in this view than it did in the other one. I do expect you to know these 4 sinuses. And look, again, if you're looking here, it's kind of easy to see where these are in relationship to the eyes. You can use the eyes. But look, when you're doing a cut through a medial section, right there, the frontal sinus, it's not shaped the way you'd think it would be, going back into the skull. And the ethmoid, look at that, it looks like a little teeny tiny one. And look, oh my goodness, all the way back there. And the maxillary sinus is huge. But there's the frontal view and there's a side view. I like this picture because it shows you, we know the frontal bone, but you don't realize how big the frontal sinus actually is. And we know about our nasal bone right there. It doesn't go very far. The rest of this stuff is just cartilage. But when you stick your finger in your nose and you're digging for gold, as I call it, picking out boogers, you miss the whole fun part. If you kept going back a little further, then you get into these concha, you get into these folds, and the little meatuses that you can stick your finger in between the folds. So it's nice to look and see where the lips are in relationship to the teeth, where these things are in relationship to the nasal bone. And look at there, the sphenoidal sinus extending back here. We looked at the hyoid bone in lab, and we saw that it kind of looks like those fake teeth that you wear at Halloween that makes you look like you have fangs. And we talked about it's the only bone that doesn't articulate. And if you're under the age of 18 and someone strangles you, you won't break the hyoid bone usually because it's too flexible. But after the age of 18, if someone strangles you or you are hung, then this will snap. In order to put enough pressure on the trachea to actually shut off your wind, you would have to go through and break this bone. Look where it's attached. Remember that styloid process, that little sharp spike? And here's your hyoid. There's your voice box. So you lifting the voice box using the hyoid, the larynx. Just a few things to think about when you're looking at a child's skull. Obviously, their skull has to grow. So you have fontanelles. There's usually one main fontanelle, the soft spot they call it, between the unfused cranial bones. And it's kind of interesting, if you look at a newborn baby, you can actually see the heartbeat sometimes. It lifts. It's very interesting. But because you have this space between the bones, you have room to grow. If the fontanelle is depressed, then you know the baby is dehydrated. If the fontanelle bulges, you know that the baby has too much too much water on the brain or too much fluid, cerebrospinal fluid. So we say that they have hydrocephalus. About the age 8 or 9, your skull is already as big as it's going to get. And what happens is this makes you disproportionately, the skull is bigger than the rest of the body, because the body is going to wait until puberty to finish growing. But your skull's pretty much done by the time you're 8 or 9. This is the fontanelle, or the soft spot, that they usually talk about. It's in the front. Here's the frontal lobes and the parietal lobes. But you do have a posterior fontanelle back here also, but it's not nearly as large. In lab, we learned about the processes of the vertebra. We learned how to differentiate the cervical vertebra from the thoracic, from the lumbar vertebra. But why do we have the vertebral column? What all does it do? So it supports your skull. So we talked about the atlas that supports the head, and the axis, which allows you to turn your head. But you also are protecting your spinal cord. And when you move, you don't really think about how much stress that you put on your body. So especially jogging, you're putting so much pressure, you're thumping your foot down on the ground as you lift one foot and thump the next foot down. But that shock of hitting the ground goes all the way up your spinal column. So you have about 3/4 of your body is of your spinal cord is, well, let me get this right. Your vertebral column is the bone itself, but then about 1/4 of it are the discs that are between the bones. And if you're one of those people that feels kind of sad because you're not very tall, if you will measure yourself when you first wake up in the morning, you'll be taller than you are before you go to bed at night. Because during the day, your discs compress a little bit because you're constantly pushing on them with your body's weight. But when you lay down at night, they can relax and they can spread back out a little bit. And if you're hanging out in the bar and you want to impress people, you can tell them that 1 out of every 20 people has a different number of vertebrae than the next person does. Usually they have an extra bone that fused into their coccyx or their sacrum. It's kind of interesting. A newborn's spine is actually C-shaped, like this, but once they start crawling, turning over, and begin to walk, the cervical region and the lumbar region become concave, so they actually bend out. Beyond the age of 3, you have an S-shaped vertebra with 4 normal curvatures. So you have lordosis of the cervical region and the lumbar region. You have kyphosis of the thoracic and the pelvic region. In some people, they overdo it. So the lordosis, the green shows you what it should look like, but if you're pregnant or you're fat, in order to maintain your balance, because this is going to be pulling you forward, you're going to have to thrust your hips back further, and so you're going to accentuate this lordosis that's going on right there. And then in older people, as their cervical vertebra crumble and remodel, they tend to cause you to bend over like this. So this is kyphosis, but this is hyperkyphosis. This is way more than you should be. Here's what's normal. So you have a little curving over, but nothing like this. And then scoliosis is where your vertebral column goes like that. So obviously that's not okay either. And it's going to cause problems with your disc coming out of alignment. So here's what this normally looks like. You normally have lordosis right there, and you normally have lordosis right there, and you have the kyphosis like that, and the kyphosis like that. So that's normal. She's okay. Things that can cause your spine to be curved incorrectly are certain kinds of disease. If you don't eat well, if you don't eat the right foods, your bones can crumble. If you have paralysis, you're in an accident, you break the spinal column, then that's going to cause the vertebral column to bend in unusual positions because the muscles aren't stabilizing it. If you just slump, if you have poor posture, pregnancy, of course, is going to pull your lower back into hyperlordosis. And then sometimes you're just born with a problem with your spine. So those are some of the things that can cause it. What's interesting is scoliosis usually, more often occurs in adolescent girls. And I find this interesting because I don't think I've ever met a girl who had, well, I take that back. I've met one girl who had scoliosis, and I've met a huge number of boys who had scoliosis. So that kind of surprised me when I found that statistic, because it's not what I have found to be true. Most of us don't talk about kyphosis. We talk about somebody's hunchbacked. Usually it's caused by osteoporosis. We're seeing more of it because people are staring down at their phones. Who knew that tuberculosis could cause you to be humpbacked? And when we get into the chapter on endocrine system, we're also going to find out that you can end up with Cushing's disease, which will give you a huge dowager's hump or big humpback up there just below your cervical region. There is a great debate going on between coaches and parents because kids before puberty want to play sports, and there's a lot of things that they do, such as weightlifting, that can actually cause their body to form incorrectly. So it can actually damage the body. Coaches want you to work out, they want you to do the weightlifting, they want you to do the bodybuilding, and I perfectly understand it. The kids want to do it so they can be better athletes, but before puberty, you are going to be causing sometimes a permanent effect on the skeletal system of the child. We learned in lab if you have a vertebra that has extra processes besides just the transverse process and the spinous process, that you're down in the lumbar region. And then we looked at the body, but we really didn't talk about what's going on there. I don't know if you noticed when you were looking at the vertebra, but the body of the vertebra has an articulating surface for the disc, so the intervertebral disc right here. And the foramen is actually back here that allows the spinal column to come through. And you notice there are openings, so that's a foreshadowing of later on we're going to talk about the spinal nerves that branch off. Each of those discs that's between the vertebra has two major parts. One of them is the fibrocartilage that makes up the outside part, and then inside is a kind of a gelatinous mass. So think about somebody putting Jello inside of your disc. So it has a little give to it. They're shock absorbers. But unfortunately, when you have something that's gelatinous, if you put too much pressure on the body of the vertebra, it can squeeze the disc out. It can actually rupture or herniate the disc. The author does not like the word slipped disc, but that's what a lot of people use. So this is why it's dangerous. Here's the disc, and there's the gelatin-like stuff, and it will actually ooze out through and compress the spinal cord. And this is not okay. So if your slip disc or your herniated disc is actually pressing up against the spinal column, you're going to have to do something to fix it. So a lot of times if you just get off your feet, lay down, like I said, your disc expand back out a little bit when you're not putting pressure on them. So a lot of times they recommend bed rest to see if you can get this to go back the way it's supposed to go. Sometimes they have to inject something in there to eat away some of this so that it can go back in. And then at the last ditch, if you can't fix it, the bed rest didn't do it, injections of something to dissolve away this doesn't work, then they do need to go in and do surgery. When we looked at the atlas and the axis, which is the C1 and the C2, they're the only ones that don't have a disc, and the axis has this projection sticking up the dens, like dens in living rooms, and here it shows you with the stabilizing ligament holding it in place. And so now you can turn your head. But because you do not have a disc in between these, the bones actually rub together. So if you turn your head back and forth in a quiet room, you can actually hear the bones rubbing against each other. And that's, it's called to crepitate or crepitation. And somebody who has a lot of bones that rub together, we say is decrepit. So we talk about older people being decrepit, and when you hear them walk, you can actually hear their bones rubbing together. But the atlas and the axis are made to do that. So until you go through puberty, your coccyx, which is the very last little bit, we call it your tailbone. It's the last of the vertebral column. They're not fused. It takes until you're 20 to 30 years old to finally fuse them. And sometimes people have 4 fused vertebrae, sometimes they have 5. Sometimes when you're giving birth, if you have a big baby, in a small birth canal, that you can break the coccyx. But usually it's by a hard fall. You slip on the ice, your feet go out from under you, and you end up landing on your coccyx. And there's nothing they can do to set it. So there's the fused sacral vertebra, and there's the coccyx right there. Your thoracic area consists, of course, of your thoracic vertebra, but it also has your sternum and your ribs. And inside, you have your lungs and your heart, so this is to protect you. It has a little bit of the spleen that it protects, and some of the liver and the kidneys also are protected. This is the picture of the clavicles and how they articulate with the sternum. Coming down here. There's your xiphoid process that's often broken when you do CPR. Here are your costal cartilages that attach the ribs to the sternum, except for the 5 false ribs, which don't directly articulate with the sternum, but they articulate with other costal cartilage. Sorry. And you have 2 floating ribs down here that are not attached in the front at all. They're not attached to the sternum. And in some ethnicities, such as the Japanese, a lot of them have 3 floating bones instead of just 2 floating bones. I wanted to throw this in because one of my students pointed it out to me and I was astounded. Back a long time ago, every little girl had to have a Barbie doll. I mean, that was the thing to have. And nobody realized that it's anatomically impossible to look like a Barbie doll. But there was a girl, and they told her she looked a lot like a Barbie doll. And she got so fascinated with it that she actually had her ribs removed so that she could look like a Barbie doll. And she had implants, and she had her eyes tattooed. So this is actually a real person. This is not a doll right here. This is someone who decided that they wanted to look like the anatomically impossible Barbie doll. Here is a foreshadowing. Once we start learning about the joints, we're going to find out that there's actually a cartilaginous joint right here between the manubrium, which is the top of the sternum, and the body of the sternum. The humerus is known as the funny bone, and you have a nerve that runs down, and if you hit your elbow just right, a pain will shoot down your arm and into your finger, usually your little finger. And it feels like pins and needles, and it really hurts. So I don't think it's so funny. It's funny, odd, not funny, haha. The socket that the humerus fits into is part of the scapula, and it's called the glenoid cavity or glenoid fossa. Normally, when you were talking about ligaments, you name the bones that it attaches. So you would think that the one that holds the scapula to the humerus will be the scapulohumerus, but it's the glenohumeral ligament. Oh, here's some jokes I had to find. If you boil a funny bone, it becomes a laughing stock. So if you take a bone and you crack it open, it's full of bone marrow. And if you just boil a chicken, you just get broth off of it. But if you will actually break the bones and release the bone marrow, then you get a richer stock. You get something that's a lot more dense, has a lot more flavor than just chicken broth. So I found this humorous. Here's another example of a fibrous joint. Your ulna and your radius and your tibia and your fibula are held together by fibrous connective tissue, so you cannot move one bone without moving the other bone. So they're connected. And I always point out the radius, the radial bone, this is the radial bone, is always over the thumb. So if you follow your thumb up, you're going to run into the radial bone. If you follow your little finger up, you're going to find the ulna. So the ulna and the radius make up your lower arm, and they are joined together tightly. Your wrist is made of 4 bones in 2 rows, so it'd be 8 bones total. And one of them you don't form again until you are 9 to 12 years old, somewhere in there. So you're constantly growing bones, interestingly enough, and you're fusing other bones. So you gain some, you lose some. If you're going into X-ray technology, if you're going into radiography, you do need to go ahead and learn the names of all the bones. But for my class, you don't have to know that. I want you to know that the name of all the bones together are called carpal bones. And one of the problems that people have is they get carpal tunnel syndrome. So right over your carpal bones, you have this really tight band of connective tissue. And your nerves and your ligaments go under it. So as you're moving your hand, you're typing, you're playing on your phone, you're doing some repetitive motion, you are causing inflammation. And if it gets inflamed enough, it'll actually cut off the blood flow, and it'll cut off the nerves that are reaching out into your fingers. So that's not a good thing. You're going to have to immobilize your hand until you do not move your wrist for a long period of time to let the inflammation die down, or they can inject you with a steroid or some anti-inflammatory thing to see if they can get it to shrink down. Sometimes they actually have to go in and do surgery and loosen this band a little bit. The famous artist Leonardo da Vinci was fascinated by the proportions of the human body. So he drew the Vitruvian Man, and most people have seen this picture before. So here's the circle and how you fit within the circle, and here's the square and how you fit within the square. When I lived in Italy, the Euro had a picture of the Vitruvian Man on it. I found this, and since I'm not male, I can't check out the hip. It says the hips are usually straight up and down from the armpit. So the outer edge of the hip, which would be the ilium, should be aligned with the armpit. This one I know doesn't work, at least for me. So I don't know whether my face is wrong or my hands are wrong. But supposedly you could put your carpal region, your wrist, at your chin line, and your longest finger, the one that you use to indicate joy when somebody almost pushes you off the road with their car, should reach up to the top of your face. And in my case, it doesn't work. So mine actually comes down to my eyes. So I go from my chin to my eyes. So I have really short fingers or a really tall face. That one didn't work. And the feet are the same length as the forearm. I do want to point this out. So here are the names of the various bones. There's the 2 rows of the bones right there. But that's the wrist, so nobody has trouble with the wrist. But most people think that this is the fingers, and it's not. These two right here on the thumb are the fingers, or the thumb, and these three are the finger. The rest of this is your palm. So you don't have long fingers like that. But when you take the flesh off, the bone just comes on down, and it looks like this. So that's always a surprise to people to think that, oh, wait a minute, that's not long, bony fingers. That's the palm. So these are the metacarpals, and those are the carpals. And then the outer three are your phalanges. This is a phalanx, that's a phalanx, that's a phalanx, that's a phalanx, that's a phalanx. It doesn't tell you in this picture whether this is a boy or a girl, but what you can do is you can look two places. One of them, you can look at the pubic symphysis. So here's where you join the two halves together at the pubis, the pubic bone, and that's the pubic symphysis. This, if it's U-shaped, is a girl. If it's a tight V shape, it's a boy. The other thing you look at is how big of an opening do you have? Can you get a baby's head through there? So if you look at a guy, their hips are more pulled inward and aligned with their armpits, or their axillary region, if we want to be correct. And a girl has got to be able to pass a baby through. This is called an immovable joint made of cartilage, but under the effects of hormone, under the effects of pressure of a baby trying to push its way through, it can give a little bit during birth. And a lot of times women's hips spread when they're pregnant. So as they're carrying the baby for 9 months, their hips spread. Sometimes they go back, sometimes they don't. I enjoyed this picture. Here's how you spell pubic symphysis. That's a F sound, symphysis. So it's fibrocartilage. I call it gristle. The name of the socket where the femur fits, the head of the femur, is called the acetabulum. And it is from somebody who looked at it and said, whoa, that looks like a vinegar cup. And the word for vinegar is acetic acid, and so they named it the acetabulum. So there's your vinegar cup. And I pointed out, and it's worth repeating, usually when an older person falls, it's because they already broke their hip. The neck of the femur broke, and because they no longer have the support of their leg, they fall. But most people go, oh, somebody fell and broke their hip. And it's usually the other way around. Their hip broke, causing them to fall. Here's a boy versus a girl. Right there. So you can easily see that's very tight, which is why girls kind of wiggle when we walk, and guys usually don't wiggle that much. You and I call this area the shin bone, but if you remember from Appendix A, it's the crural region. Looks like you're trying to say rural, but you put the crural on it. And the upper part where your femur is your thigh. Here's the neck of the femur. There's the ball. There's the neck. And that's usually what breaks or gives way. It gets so thin it can't support the body, and so it snaps right there. And remember, little kids are born without kneecaps. If you have skin on your fingers and you have skin on your toes, we call them digits. But if you take the skin off and you're just looking at the bones, we call the fingers and the toes the phalanges. Now, again, we have the same situation we had before. Your toes are not that long. But if you look at a skeleton, you think, whoa, he's got really long, bony toes. But only this last three right here are the actual toes. And so the ankle is called the tarsal. The tarsal. And then the metatarsals make up the arch of your foot. Two bones you should know about are the talus bone, which articulates with the tibia, and the calcaneal bone, or the calcaneus. And this is because the Achilles tendon attaches to it, and it helps your calf muscle work, your gastrocnemius muscle. So the calcaneus is the heel bone. The metatarsals give us an arch in our foot, but some people, because they're overweight or because they have lifted weight, they've done a job that you have repetitive stress on your foot, it can cause your foot to go flat. And so that was in the time of the draft. If you had flat feet, you could get out of doing compulsory military service because you can't walk as far if you have flat feet. Here's a couple of fun things that you can do to your feet. You can get what they call hammer toe. So there's an example of it. Another example. This is usually caused by wearing shoes that don't fit or from wearing high heels. So guys don't have as much to worry about as the ladies do. And this is a bunion. And this is actually a bone sticking out there because this person is flat-footed. So once you collapse the arch, this bone juts out. So it makes it really hard to find shoes that fit and that are comfortable, that don't rub against that bunion. Here's an x-ray of the foot, and it names all the bones. Again, if you're going to be going into radiography, you need to learn this. All the bones, which ones are which ones make up the arch, the calcaneal. Here's the tibia coming down on the talus. There's your metatarsals, your phalanx. Now, look what happens when you put on a high heel. Look what you did to your toes. That is so not normal. And this is interesting because this one is wearing an ankle bracelet. And you're like, why is it sticking out like that? Because there's the flesh going down to the heel. I hadn't really thought about the fact that humans are the only animals that almost always, habitually stand upright. That's what bipedal, we have on 2 feet instead of down on all fours. So you think about cats can stand up on their hind legs, but they don't like to stand up there that long. Elephants can do it, dogs can do it, but they don't like to do it. They generally tend to want to be on all fours. I'm going to finish up with one of my favorite Far Side cartoons. This is why cows and hooved animals don't have telephones, because they don't have opposable thumbs. You and I can take our thumb and go across our palm. So that's what opposable means. And so we can pick up the telephone receiver. Of course, nowadays, since everyone has cell phones, a lot of people don't even know what the receiver looks like on an old-timey telephone, so they may not get the humor of this cartoon. And I would like to tell you, don't forget go over into my YouTube section and find Lab 5, which will tell you about the skull and the vertebral column. So that's your axial skeleton. And then go to Lab 6 and watch that video, and it will tell you about your arms and your legs and your shoulders and your pelvic girdle. So you need to know some of the processes. You need to know the names of some of the bones. So that's it for Chapter 8.